Hi, this is Dr. Krishna. I'm a consultant physician based in Hyderabad. And welcome to Steths and Sip. This is a short form for Stethoscope and Sip. This is a series of very interesting, very innovative talks with experts in the field of medicine, where you will get unique insights. Not only unique, you will get unfiltered and unfettered access to the inner thinking of a experienced clinician in Indian settings. So, welcome to this very interesting talk that we are going to have with an industry specialist today, that is Dr. Jyoti Budi. See, from understanding her achievements from my point of view is actually, it will not give you the whole picture, but let me give you few insights about her. She is a very prominent figure in the field of infertility, and she is the head of 39, which is a very known and established organization for infertility cases, and it is kind of a referral center for highly complex cases of infertility, especially for couples who are not able to conceive and who are already have gone to multiple infertility centers. They were found to have success in this center. So without any kind of delay, let me request Dr. Jyoti Budi to give her, welcome her to the show, and I will request you to give a brief about your, I have seen your profile, I've heard about your profile from many of my friends. So I would like to hear it from you. What made you come into this fertility field? Where are you from? A little bit about yourself.
Yeah, thank you for that kind words. So basically, I'm a gynecologist, fertility expert, and Dr. Jyoti Budi, medical director of 39 Fertility Organization. Today we are with 11 centers across AP and Telangana. So if you have to ask me, it started in 2013, almost 12 years back. Back then, basically finished my gynecology from Bangalore, MS Ramaiah University. And then fertility was always very close to my heart, because this is a field where a baby, even before it's born, it's in our hand,
Absolutely.
So we get it to the world. So it was a very close to my heart, and got knowledge and all my degrees from different parts of the globe. MS from Homerton University, London, and advanced ART specialized from Dubai.
Yes.
Various parts of the country, and only with one intention of doing quality care in our country and in our city, AP Telangana. That was the first idea of this. And as soul level, if you see, wanted to do ethical practice, which is very transparent and concerned to the patient. Just like any patients come in front of us, how early they can go with a bundle of joy baby. That was the only idea when we started the center.
Wonderful. So one thing that Madam has not said, and I would like to add, Madam is also a teacher, and there is an active fellowship program which 39 gives for infertility. So this is also a great service that Madam and the organization is doing for the upcoming gynecologists, and helping them, train them for making a standardization in this field of infertility, because there is a very high need. Every center has its own protocols, so we need a more standardization. So we'll be talking about that also in detail in our talk. So Madam, there is a big contradiction. We are the most populous country in the world. We have crossed 1.4 billion. At the same time, the cases of infertility are rising.
Yeah.
So what is happening? Why is this a contradiction? What do you think are the major factors that one side we are having high population, the other side infertility treatment? A lot of couples are seeking for this. What do you think is happening?
See, end of the day, if you see all the analysis, as you have told, I can echo with your words. One side, we have even crossed China population.
Yes,
we are the number one leading in the whole globe now. But if you see the census of fertility, the fertility index, and there is a raise in the infertility numbers as well. So there is drop in the fertility rate compared to 10 years, 20 years before. There are many things associated with these change. So people who are having kids, they're having, but people who are suffering are still suffering. So one of a major change in our country, if you say, I can attribute to the age of marriage.
Okay.
Shift in the age of marriage, especially women. 20 years back, most of the ladies used to get married at 24. Now it's 30, 29, latest census. So in these 24 to 29 years, there is something called as window of fertility. The high chance of becoming parents are at this age, less than 30 years for a lady.
Okay.
So once she crosses 30, the window closes. So then when they want to plan for a pregnancy, it becomes very tough. So, and also contrary, our Indian women can't be compared with the Western population. There is a Spanish study which says Indian ovary ages faster, 8 years faster compared to other ovaries.
Okay.
Like menopause, if you see in other countries, it is 45, 55,
Yes.
but in our country, 48.
True.
So almost 8 years we are ovarian aging is there. So that is one. And second is about sedentary lifestyle. If you see, everything is available. So the things have changed. You have many apps, Zomato, everything, you just call, people are not moving. Sedentary life is one of the major factor.
True. So let me ask you a question about this PCOS. Nowadays, we are seeing a lot of patients with PCOS, especially women who are working and because of the lifestyle changes. So how prone are these PCOS patients to get infertility?
Yeah, there is, of course, in PCOS, there is subfertility, not total infertility. See, what exactly happens is, what is PCOS? It's a metabolic syndrome. So there are, in the ovaries, lot of small follicles are there. Along with that, they have irregular cycles. And little male hormone, testosterone, is little more compared to the normal ladies.
Androgen excess.
Yeah, yes. So with all these, what happens is more than estrogen, testosterone levels are little higher in them. So with this, there are subfertility. So ideally to say they have difficulty in conceiving because the cycles are also irregular. And if you see now, they were epidemic of PCOS. One of the factor is sedentary lifestyle, increasing weight. So basically, prone, if we say, I always tell, many people come with their kids. My daughter is having PCOS, how do I manage now? So usually it's a combination of a genetic and a external environment factor. The lady will have a genetic issue.
True.
But when it comes hands with the environmental factors like change in weight, sudden gain in weight, this ovaries won't function well. It becomes cranky,
Yes.
Their cycles become irregular. So immediately once they reduce weight, again the ovary starts functioning well. So one of the important factors is weight control. They can live like almost non-PCOS once the
with
weight
good
is,
lifestyle modifications.
Yes, of course. And science says, evidence says, without any treatment, almost 70% just by reducing 5% of their weight, their cycles becomes regular.
Okay.
And 30% they conceive naturally also.
A good IVF center, in your definition, should have what? Because we have seen very small IVF centers cropping up. There is a boom in IVF clinics. That is what I'm seeing.
Yeah.
And I feel personally that not all centers are fully equipped to handle all needs of infertility. So what do you think an IVF center should have? And what are all the things that should be covered in this IVF center?
Very interesting question, actually. To be very honest, I can tell my own journey as well. We always think as a clinician, we play the main part in a fertility treatment. But to be very honest, there are embryologists who are sitting in that temple, what we call, IVF lab, and working behind the screen. They are the one who handle the gametes. So that embryology lab, I always consider it as a holy place.
Okay.
So that has to be taken care very well. So along with the clinician, the embryologist plays a crucial role in fertility treatment. Because the baby, even before going to the mother's womb, it stays there for some time. So it has to be handled very well. So to be very honest, we have a European person, Mr. Javier, who is taking care of lab. The SOPs, the stringent QA/QC, we call it as quality control and quality assurance. The way they handle it, it's really something, mind blowing it is. So end of the day, how safe the embryos are handled, especially when the gametes is outside. We have something called as a RI witness system, where we have a QR code generated for the lady's egg and the husband's sperm, and their embryos are tagged.
Okay.
So there is no question of mismatch.
Excellent.
So to be very honest, in AP and Telangana, we are the first one to take it forward. It is, you can do without that. But end of the day, when you have all this luxury in place, your confidence level in treating the patients, your success rate, everything, it multiplies.
It gives installs a sense of confidence in the parents also, that because we have been hearing a lot of cases, especially with infertility doctors abroad, Western. There was a interesting case, I think in States, where one infertility doctor used his sperm and was the father of maybe 30-40 children.
That is right.
So that is
that's what. See, end of the day, when patient come with so much of trust, it's the responsibility of a doctor, because everything they put on us. I always feel when we are having, example, 49 is a chain of 11 centers. We have 30 doctors with us, more than 50 embryologists. See, one person can't, it should not be like manipulative, as you told. See, when so many people are involved, we have an SOP, standard operative process in place. So it's not one person's decision. So you have to have a SOP for all these parameters. In one way, I can also thank our government, Indian government. They got a strict ART rules, considering all these, So things have really different now. There are rules that even say, suppose third-party reproduction, when we go for donor egg or donor sperm, they can't give, only once in lifetime they can give their sperm or egg. Okay. It is so stringent now.
All right.
We even, Aadhaar card is matched with the recipient. So that's something really, I think we were also looking forward, because as you told, there should be some standardization, Patient should feel safe.
True.
So all these are changes which are happening, and we in 49, we are the first one to adapt and align towards, ethical practice, standard of care, and safety to the patient. So having RI witness system along with an alarm, we call it as Iltrix. So this makes us doctors, when you go home at 6 p.m. after the end of the day, you feel your embryos are safe.
Okay.
So it plays a very vital role for us.
Wonderful. So you have talked about the ART regulations in India. A little bit, let me dwell into that. The first thing I want to ask you is, tell us more about the surrogacy aspect, because there are a lot of misconceptions, and there is a lot of cloak and dagger or cloak and hide kind of situation, because it's a very sensitive topic.
Yeah.
So how do you source a surrogate mother? What are the parameters? In which conditions you go for this? So kindly elaborate a little bit.
Yeah, of course, surrogacy. In 2021, there was ART law in our country, which seeded in our country. It was a wonderful law. Before that, nobody knew what to do when a lady comes, seeking for pregnancy. See, most of the time, everybody knows about celebrities for surrogacy, and they think, okay, that's what his life is. But end of the day, we as doctor sitting in front of patient, we have many ladies without uterus. She's born without uterus. Some ladies are born with the uterus, which has to take the baby for 9 months, not functioning. There are so many fibroids, or the baby's bed, I call it as endometrium. It's not functioning well. It can't keep the baby. Now, what do we do for these ladies? There are almost I can say 1 to 2% of ladies with these problem. So but before 2021, it was very tough for doctors. Because anytime we take the surrogacy, we are always worried. But then after 2021, very strong law was in place. It's very easy now. In fact, for doctor, it is very peaceful. So how it is, basically, government is involved now. The state authority, the DM and HO of the state is involved in decision making.
All right.
See, once a third party is involved in decision making, doctor's life become very simple. So now everybody knows there is something called as eligible criteria, essential criteria.
Okay.
Two very important criteria to make it very simple. So there is essential criteria. That means to say, this woman who has come now, she needs surrogacy essentially. There are only 5 conditions. So first is if she doesn't have any uterus. Some ladies are born without uterus, absent uterus. Second is a small uterus. They have, but it's not working. It's very small. It can't take the baby for 9 months. Third is there is uterus, but the baby's bed, we call it as endometrium, it's not functioning well. It is very thin.
It's not responding to
progesterone.
progesterone.
Not responding, Asherman syndrome, all that. Fourth is when there is fibroids or recurrent implantation failure, 4, 5 times, 3 times if she has failed, or abortions. And fifth, if pregnancy becomes danger to the mother, like life-threatening cardiac problems or health problems. So very clear 5.
5.
So we see couples and we say, yes, surrogacy, you have essential. So you can go to the board, state board, apply for it. That is the first step. Second step, a surrogate, usually it's an altruistic surrogacy now.
Okay.
They have to have their own surrogates, the commissioning couple.
All right.
So they will get a surrogate, and is she eligible for surrogacy? Second criteria. So we have psychological, her status, because she has to take the baby for 9 months. And then is she fit medically?
Okay.
So a psychologist will give a fitness, a physician will give a fitness, and then we as a gynecologist, whether she can carry the pregnancy for 9 months. We see the scan uterus. So all these fitness again goes to the state board.
All right.
Now the authority will decide she is eligible or not.
It has become more like a transplant.
Yeah, something like that.
Okay. I was under the impression that infertility centers source surrogacy. Now it is not like that.
No. Totally we are isolated now. We do just like, what we are doing IVF ICSI, we do for them. So everything is through the state authority along with the legal authority. We have a legal team. Even couples can have their own legal team. So they decide and give us the, all the box tick. Then we do IVF for them. Okay.
IVF centers, do they require some accreditation, board accreditations? Like when I was in a corporate hospital, we had NABH accreditation. And labs required NABL accreditation. Like that, what accreditation, I mean, for people who are actually searching for a IVF center, it would be like a pointer saying that this is an accredited center. So what is there for that?
See, for a license part, if you have to see, we need the state authority who comes, sees all the center. There is something called as level 1 and level 2 fertility clinics, ART clinics.
Okay.
Level 1 is very simple. You can, do a follicular study, basic. And then an IUI can be done in level 1. But level 2, like IVF ICSI, the advanced, when we have to do level 2, there is a application goes like a level 1 clinic and level 2 clinic. So it is authorized by the state authority. Again, they come for inspection. And if you want surrogacy, you'll have to take another license specific for surrogacy.
Surrogacy. Okay. So that is in primary centers, for example, in districts. So I don't think so there can be a level 2 or beyond that.
Many centers in the districts also, they have got a level 2 license.
Level 2 license also.
Yeah.
So there is no countrywide accreditation board, nothing like that.
So the same ART is not state authority. It comes through the nation. The whole law is placed from the central government itself.
Okay.
So they have their own channels in the satellite in the state. So it is through the national board itself, from the country itself, national authority. And of course, this is the basic requirement. But when it comes to kind of advanced treatment and kind of standardized, we even have our ISAR, we call it as, it is a union where we have Indian Assisted Reproductive Society.
Okay.
We have got accredited with that.
Okay.
So there are some state authority, national wide authorities we go for accreditation.
So accreditations, there is a standard accreditation for this.
ICMR was there before.
Okay.
Yeah, it's a part now. Before it was like kind of most of the accreditation was through ICMR. Now state and center has taken more of the accreditation.
Oh, wonderful. Do you get infertility cases from abroad?
Of course.
Okay.
We do get.
Which country or which place? Mostly Gulf, if I'm not mistaken.
Today I saw 3 patients all from different part of the globe.
Okay.
One was from Canada, one was from Australia, one was from Sudan. So basically what they view our country is, especially people staying outside India, kind of cost becomes a major factor.
Definitely.
It's almost 10 to 15 times what we charge here.
Yes, true.
And waiting list is a lot, especially
Absolutely.
European countries, they have their NHS system. So there they have to wait for a long time.
True.
So even a clear-cut case of IVF, like tubal blocks, direct IVF, but they have to wait for months and years together. So that luxury, I think, in our country, both the affordability, quality, everything India is now raising,
Medical tourism. Many of the corporate setups are into medical tourism.
Yeah. And safety, everything it holds in place. So we do see patients. And another way to put it is in different countries, especially when it comes to fertility, see, their race is different, our genes are different.
There are cultural issues also which
we go faster age. So we can't wait until, for European 40, 45 is still okay. But for Indian women, 40 somewhere they start hitting menopause then.
True.
That is also something.
Wonderful.
We have to be careful.
And IVF center, apart from the gynecologist and the embryologist, male infertility, I have read somewhere, especially WHO says that it's around 30 to 40% is because of male infertility.
Yeah, exactly.
So andrologists are also required. So what else? You do genetic markers also, those are also important when you are going for IVF.
Okay. Andrology, the first part of is andrology, 45% is because of male issues now. So if you have to say about male infertility, we gynecologists are also trained to do andrology because it comes as a part of the learning curve. But when it comes to sexual disorders, sometimes, people may want to see an andrologist. But end of the day, if there is a clear-cut fertility issue like sperm problems, there is less sperm or zero sperm, we are really equipped, all fertility experts are equipped to deal with male infertility as well. So
we have correction surgeries and we also have testicular aspiration.
Yeah, everything.
All those things.
Yeah. All in 49 in one, roof. We have all the treatment for all, say it is women issues, say it is male issues, or sometimes collectively there will be unexplained infertility. Both of them will have challenges.
Okay.
So everything is available in one rooftop.
Okay. What about geneticists? Do you even take services of geneticists? And how regularly do you require a genetic screening?
Yeah. If you have to talk about genetics, normally basic genetic fertility requirements, like, we have something called as PGTA, pre-implantational genetic screening, where lady comes with repeated abortions, or if she's very elderly, above 40, where aneuploidy like trisomies all are common. So for these basic requirements, they don't have to specifically go for a genetic help outside.
Okay.
We do IVF, ICSI, PGTA, and these are sent to the genetic lab. So, and for this we have to take license separately, of course. And then all the genetic, whenever we use genetic markers, that we will be submitting it to the state also. That Of course, not for everybody. So some part of conditions where we need genetic inputs, we are tied up with many genetics, and we have counselors also in place for people who need support.
Especially with newer techniques like mitochondrial therapy that is required.
Yeah.
So you need more genetics.
To be very honest, recently I'd been in Tokyo about all this mitochondria, three parents for a baby. Still, it is not taken very well off. It's still in the experimental. Hardly one or two handful it has been done. So until and unless it is tested, it is scientifically proven, then we can use it in our patients. So right now, end of the day, what we see patient is how can we use our science, how can it be affordable for them, and how easily they can go with the baby is what is the focus.
What should an upcoming gynecologist who is in the third year of residency, if they are interested in infertility, what is the logical step they should take after they finish their residency? What should they do next?
Yeah. So now, fertility, as gynecologist, you see normally, say suppose you have 10 patients, 4 patients invariably you see infertile patients. So there should be a learning curve.
Okay.
So when we see our gynec, it doesn't cover fertility per se.
It doesn't.
It doesn't.
The curriculum does not cover.
No, it doesn't cover. So once they finish their PG, they will have to go for a certification course, fellowship in any reproductive medicine. We do have with the board, FRM, a fellowship of reproductive medicine through the state board and national board as well.
NBE has it.
Yes.
Okay.
But then we do, example, if you see in 49, we have trained more than 500 doctors in this field, especially from districts, periphery. So we have some basic course and advanced course. Basic course is when a doctor comes and tells us we don't need advanced, only level 1 training we know. We'll take only level 1 licensing. Basic follicular study and IUI we teach them in a basic course.
Okay.
Some people who wants to pursue their life as a fertility expert, they need to go with the advanced course. So we have 6 months fellowship program, 1 year fellowship program where we train them for all the procedural aspects in the field of fertility.
Wonderful. I would like to ask you, we have a lot of medications which we use for infertility. Especially, let us focus on the women aspect of it. So we have FSH injections, we have HCGs, we have HMGs, we have GnRH antagonists like cetrorelix. We have agonist protocols like leuprolide. So this is more like I would like to understand more. Where do you usually go for the agonist protocol and where do you go for the antagonist protocol?
So when I started my career, it was only agonist. There was no antag available. It's just maybe since 12 years it's there. Then we had that was the reason where we had so many side effects like OHSs.
Yes.
And then, fresh transfer, multiple pregnancy, all this was there before. But then ANTAC came as a blessing for all the fertility experts, where we have a protocol called ANTAC protocol with agonist trigger.
Okay.
Where most of the clinic, I can tell you, it has become OHSS free clinic.
Okay.
The major side effects of fertility, before going for an IVF was a kind of putting the patient little, unsafer zone.
Okay.
But now after this protocol, you don't have to worry at all. It has become so safe. It is hardly only even the prick of the injection with this pen. It has become so easy. Quick 8 to 10 days of injection. You give ANTAC protocol. You call her on day 2, 10 days of injection. Give a agonist trigger. Freeze the embryos. Transfer. So safe and so simple. There is no multiple pregnancy. Most of it, singleton. And also, OHS is free clinic, it is. No side effects. Almost.
Can you elaborate on it? For my understanding, how do you go about it? For example, you have a 40-year-old woman who has come to you with a low ovarian reserve. She has presented to you. Husband has a good sperm count, around 60 million. And how do you go about it? How do you evaluate the woman? And let us say she's quite healthy, she's not overweight. So just tell me.
So this is a very day in and out the patients we see. The example what you have quoted. End of the day, any woman wants her own genetic material. She wants to become.
Absolutely.
She wants to have a progeny of her own genes. So we as doctor become very emotional with them. Our challenge is to make her a genetic mother. Having said that, 40, if her AMH is very less, it's a challenge.
Okay.
Because what exactly happens is as they grow, their AMH comes down, egg counts fall, and chances of abnormal babies become more.
Okay.
Down syndrome, everything. So it becomes a very challenge for the doctor to make her a genetic mother. But then, yes, of course, we do IVF ICSI and then we do also a genetic testing. But it is not so easy compared to what we see a lady with 35, 30s.
All right.
Tough, but physical body, both mental body, emotional quotient, we have to talk to the couple, prepare her for what she's signed up for. And end of the day, natural chances also can happen even with less AMH. We have to tell her she has to try naturally. But then when it comes to treatment and fertility, IUI is not an option, good option at 40. IVF ICSI is always a best option when she's around 40. We have many couples conceive at 40.
Okay. So you start off with what markers first? What investigations do you do for this hypothetical case?
We call them, we see their scan first because it's both the seed and the soil.
Okay.
Her eggs should be fine and her soil, the uterus should be fine.
Okay.
So we see the scan and we do something called as antral follicular count, egg count basically.
Okay.
Generally for a normal lady, it is around 8 to 10. For these women, it is somewhere around 4 to 5.
All right.
So 4 to 5 is good actually. Sometimes we see 1 or 2, very few. So I tell them very simple way. If there is, the rice, then only I can cook food. There is no rice, how can I cook food? So they come with very few of egg count. And then we also do another marker called AMH, anti-Mullerian hormone. So both we'll take into consideration and then start the process.
If AMH is not very low, what next step do you do?
Invariably, when she's 40, AMH will be low. But if it is normal, say suppose AMH, and egg count is still good, we'll tell her in 6 months you plan for pregnancy. You lost already time. Now 40 is like, many things happens in the body.
40 is the new 50.
For fertility,
yes.
If you think in women empowerment, they say 60 is the new 30 now. So, but fertility is something people should be aware of. Now that we have something called as oocyte cryopreservation.
All right.
Like we have many ladies coming at 25 and saying, I don't want kids for 10 more years, preserve my eggs.
Usually a lot of actresses.
No, it has really percolated to many women.
Yes.
Especially I see a lot of IT crowd and even ladies not getting right partner. They don't want to force themselves for a marriage. They feel having their eggs, like I always tell, before I was not promoting, oocyte cryopreservation, but then it is a security for them.
Yes, true.
Once they have their eggs, they don't have to worry about kids of their own genes.
Good. So, once you found that AMH is fine, what next? You say that within 6 months you need to plan it.
Ideally, when she is 40.
And then what do you do? What do you start next?
See, we are very clear of what we have. End of the day.
Because I'm trying to get into the trade secrets. If you
not like trade secrets. See, it is. I always tell this when couple ask this. If a person come with a cardiac arrest, heart attack, we don't have time. We take them to theatre, give them all the treatment, and try to save him. But here it is not like that. A life has to come.
Yes, true.
So the couple, the doctor become same team. One team, one dream. How early they go with the baby is the idea. Having said that, they should also understand with 0.00004 AMH also they can conceive naturally.
Okay.
So we tell them, I clearly explain them there are 4 windows. One is natural trial. This window has to it's to be open. You should keep trying naturally. It's your right to try naturally. Maybe there is something called as fecundity per cycle. The capacity of a couple to become parents in one cycle. For a lady who is a couple who are 25 to 30, it is 25%.
Okay.
When they become 40, it drops down to 4 to 5%. So still they can conceive. 4 to 5% is good. But then next is tablets. When we give it, doubles the natural pregnancy.
Okay.
When we give tablets, 3 to 6 months we give them. Then when we go for IUI, it increases 4 times compared to natural.
What tablets are we talking about?
We give basically, we stimulate the ovary. Very safe tablets.
Clomiphene?
Clomiphene is
Sold
not
now.
much. Letrozole we give.
You are giving letrozole.
That is aromatase inhibitor. It just stimulates the ovary and gets the follicle ovulation induction.
And you check for...
ovulation we check.
You check for ovulation and you give a trigger.
And then we'll tell
But if
them
you
to
want
try
multiple
naturally.
oocytes, then you...
No, it is for IVF. We have to start with gonadotrophin injections.
Yes. So
I will explain you. Normally, a lady without any medicine, she ovulates.
True.
Out of 10 eggs, 1 egg is released every month ovulation.
It can be anovulatory or...
but most when she has a cycle, 90% ovulation.
Ovulatory.
But with tablets, 1 or 2 eggs may come.
Okay.
So twins can happen. When we do IVF, we want all the 10.
Yes, true.
So we start on day 2, we give gonadotrophins.
Okay.
And we try to collect the eggs as possible.
So what do you choose? HMG or FSH?
We go with the combination.
Okay.
So having said that, one question everybody asks is, once you take my egg, will I be depleted throughout life?
Okay.
It's not like that. So only that month eggs we can, when gonadotrophin dependent receptors are there. So only those eggs we can, harvest. Again, it's like an Akshaya Patra, they say, it keeps producing. So they don't have to.
They attain the menopause.
So that misnomer is IVF, the fertility doesn't decrease with IVF.
So you said a combination of gonadotropins. What is your criteria for choosing what is the combination?
I'll be very honest here. If you go abroad, some people go with FSH, some people will go with HMG. It's all, again, their core belief. For some women, FSH may not work. Out of 100, for 80 it works, 20 it won't work. In a HMG, out of 100, 80 it works, 20 it won't work.
Okay.
So what we have made protocol in India, and we in our own unit protocol, we take 3:2 ratio, like how in body it is produced.
Okay.
FSH 3:2.
Yes.
So we start our medication FSH, say suppose 225, HMG 150.
And this is true for people whom you are suppressing, GNRH suppression.
So you don't have to worry that, I didn't give this, you're given both.
I mean suppression of inherent FSH and LH.
So we are taking, when you go to IVF, when you start giving gonadotrophins, HPO axis, because we are doing an ANTAC protocol. So once FSH and LH is given from outside, the follicular, that wave, everything is in our control.
Okay.
So HPO axis is quiet.
HPO axis is quiet.
Yes.
And especially, I think you'll be supporting this with progesterone also, because you want to...
No. Idea is to collect the eggs.
That's all.
So we only give FSH, HMG, collect the eggs, then very simple it is.
Because my understanding, because I'm not a gynecologist, I'm a physician, is that the negative feedback for GNRH is actually estrogen and progesterone. So how can...
So ANTAC we are starting, right? So once you start ANTAC, the HPO axis doesn't release LH surge. The premature LH surge is already controlled.
Okay, it's already controlled. Good enough. Yeah. So what is the size of the oocyte that you are comfortable?
Ideally, when we have to trigger, we call it as 17 mm follicles, 3 or 4 are there, we trigger with that. 17
mm. Yeah. And you evacuate them with laparoscopy? Or
no.
How do you...
It is a transvaginal ovum pickup we do. It is a very, very maybe 5 to 10 minutes process, no laparoscopy.
Okay. And how regularly do you do a follicular study in these patients?
Maybe 4 or 5 times patient has to come to the
4 or
center.
5 times.
Yeah,
And that is from the cycle's 5th day?
Day 2, day
onwards.
5, day 7, day 9.
Okay, good. And you give a HCG trigger?
Not HCG, that's what I was telling. HCG can cause OHSS.
Okay.
So we have something called as agonist trigger now.
Okay.
90% patient go with this agonist trigger. So we don't
what do you
have
use agonist?
So it is like leuprolide, decapeptyl we have.
Okay.
So we have all the agonist trigger in place.
So leuprolide, you use it at
0.3.
0.3.
Decapeptyl
3.75 mg?
No, that is depot. That is a different ball game.
Okay.
We should not use that.
Okay. So use 0.3.
Yes.
Okay. That causes ovulation.
That only for, not, basically it ruptures, it helps us in LH trigger. It is a surrogate LH.
Okay. So I got great clinical insights from you. Now I come to the most picky questions. What do you think is the cost? Cost does matter, and these are highly specialized products, and it's labor intensive, equipment intensive. So the cost is a very important factor. And recently I've also seen that the Telangana government established an infertility center in one of Usmania or Gandhi. I'm not sure
Gandhi,
about it.
yes.
So
we have our own doctor there, fellowship doctor trained from us.
So I would like to understand what is the cost implications, and about the cost factor. Is there a way to reduce the cost? What are the steps that you personally take to see that the patients don't suffer in this aspect?
Very good question, and this is the need, because end of the day, when they come for fertility treatment, as a normal couple, first is safety for the mother and safety for the baby, unborn baby. Third is, of course, no side effects. And fourth is cost. So we have to balance as a doctor. So what we do in 49, we have made our own unit protocol. See, before even going for an IVF, there are 1,000 tests to be done. So we have made it so clear to the patients, we don't do too many tests. Because we know by talking to patients what the problem is. So ideally, see, the perception of a gynecologist have to change now. Not to waste too much money on so many gene polymorphism tests are there.
Yes.
You name it, NK cells tests are there. But will it add value to the treatment? Not at all. So we in our center, all my 30 gynecologists, if they write any extra test, they are questioned. You do a test, you should apply it as a treatment. If there is no treatment for the test, just to know what the problem is, don't do test. So there you can cut down a lot of cost. So ours is, as you told, is a referral center. When they come to us, they come with these bundle of case sheets where 2-3 lakhs is already gone for
already
tests.
Evaluated thoroughly.
Yeah, but no, actually when we see that, we say it's not required actually. Because patient also, poor people, I feel, they keep going to different places, knocking door of every doctor. Again, they're subjected to test. So I tell them I won't do any test. Whatever is here, I'll absorb. Because end of the day, if wherever you do the basic tests are fine. Talking to patient, giving more time, you'll know the real issues. One basic scan, one good sperm analysis. These are just enough for treatment. And of course, any health issues like diabetic. Then comes IVF treatment. When it comes to IVF treatment, we should know where to use the cost for. End of the day, if you say there are, centers, I should not tell centers. As a doctor, our idea is to give pregnancy at the best affordable price. That's all we want, very simple. So, but then when a baby is created in lab, it needs lot of SOPs. There is media involved. There are dish to be prepared. There is a machine. How much ever you work on the cost, we have to be very honest. I was really surprised seeing our cost and seeing somebody outside AP and Telangana also, when we compare, 2 times, 3 times more than us. So though we have an European person taking care of lab with all our SOPs, still, very, very affordable for the patient. With RI witness system, with Ziltrix alarm, these are, I tell them this, There is no compromise in quality, but still very affordable. That is what is our idea is for patients.
Wonderful. So you do use generics in your practice, or do you stick to original manufacturers for medicines?
It all is, again, end of the day, quality can't be compromised. So we have to go with, because these injections should be very well manufactured. Patient should not have side effects. So authenticity of the company is also very important when we take for the patient.
I understand. Thank you very much, ma'am, for sharing such a wonderful insights.
Thank you.
You're great, and I wish you all the best. And I wish you that you make more couples.
39,000 already. Hope many more to add.
And you train more young gynecologists to follow in your footsteps.
Thank you
very much.
Thank
ma'am.
you so much. Thank you.